Hi, my name's Sue Fuchs and I'm a forensic nurse practitioner or forensic healthcare practitioner with Kent Police. I'm also Vice President of the United Kingdom Association of Forensic Nurses and Paramedics. As part of our Forensic Healthcare Week, I thought it'd be nice to share some of my experiences, having been one of the original custody nurses, as we were known then, with Kent Police, and when we started in 2001. Prior to this, there was lots of concerns about deaths in custody and risks of adverse incidents in custody and how to prevent them. And this led to Kent's pioneering scheme. So initially there were 5 nurses employed on a 6-month contract, just to see how it all went, and whether there was a need for the service, and it became very obvious very quickly that there was. Prior to that, we had FMEs or police surgeons who were generally GPs. They covered a very large geographic area. This led to delays in attending for healthcare issues for detainees, or for blood samples, or for intimate samples. There were changes in 1993 that led to all of this. The Royal Audit Commission on Criminal Justice looked at replacing FMEs and finding alternative healthcare service. And then the Home Office Working Group on Police Surgeons did a review. This led to the safer detention and handling of persons in police custody, and then national occupational standards. This review and the writing of these standards highlighted that this was a provision that needed to be filled. Strangely, initially we weren't seen completely as a positive addition, even by some of the custody sergeants, but certainly by some of the forensic medical examiners. We tried to work together with them, and after a few months, we did collaboratively work a lot better together, and we had so much to learn from the FMEs in the early days, obviously. But yeah, it was a strange time, and custody sergeants would frequently challenge and question our decisions, especially if it meant a detainee being moved out to A&E, because of course it would take up police officers to do the transfer and to stay with the detainee until they'd had their care in A&E. Many tasks that we now do, we couldn't do prior to 2003. It would take hours at times for FMEs to attend, and this just led to more stress and pressure on the custody sergeant, because it was his sole responsibility to get healthcare for the detainees prior to nurses starting. It was clear the change was needed, and as I say, that's what happened in 2001. Nurses could do so many of the roles of the FME as long as they'd had the appropriate training, of course. And in 2003, PACE changed their wording to include HCP. So that meant that we were able to then start taking on extra tasks, strengthening the autonomous advanced role, and we all embraced it. The introduction of PGDs, verification of death, giving evidence in court, that was all added strings to our bow. I remember in the early days, we would go to court to give evidence quite frequently. Now it's quite a rarity to go, and probably like with all of you, it's for drink driver bloods, RTA, impairments. They're generally the ones, failure to provide, that sort of thing, needle phobias, that we get called to court for. In 2004, Kent also introduced court liaison into custody. So they were, they were CPNs, and again, because they could do all the mental health assessments and progress if needed to proper mental health act assessments, that again was an FME role that was no longer needed. We did have drug treatment workers in custody around that time as well, but that's now been taken over, as has the court liaison, by criminal justice liaison and diversion, and we all work so well together, and I'm sure you probably all find the same. So since 2001 there's been a quantum leap in the roles that we do, and with the introduction of paramedics in custody as well. I mean, they bring so much experience that we can all learn from each other. It's an enhanced service now. There's operational efficiency. We have a really good bond with the teams that we work with. We all respect each other. We've just come such a long way, and it has resulted undoubtedly in reducing deaths and adverse incidents in custody, despite what some papers might suggest. But certainly in Kent, that is something that we have certainly seen. It also became obvious that, you know, in this role we needed some networks or an organisation to support us, and this happened in 2004. I was asked to attend a meeting that was being run in London, and it was a meeting of people that were either working in sexual assault referral centres. Obviously there was far less of us then working in custody, but there was a few around. So we did have this meeting in London, and that's when UCAFN, as it was then, was set up by Joe Delaforce and a few others. But now UKAFNP have also come on leaps and bounds. We're supporting all our members. We have run conferences. We're going to start doing some more webinars, and we've changed the guidelines with Taser. So there's so many developments going on that it's just in partnership with the development of the role, certainly that I've seen since 2001. Out of our original 20 custody nurses, as we were, there are 4 left still working as custody nurses, me being one of them. Goodness knows how much longer for. The other 3 either work in Kent or they work in other constabularies, but we all still keep in touch. So that's kind of my story. But it just shows that the boundaries between medicine and nursing has eroded, and the role is continually expanding with positive impacts. Enjoy the role, enjoy this week, and I think we're all doing a grand job. Bye.